Guyton-Hall Textbook of Medical Physiology, Chapter 11. You must watch this video full screen in order to see all figures very clearly. Chapter 11 is about fundamentals of electrocardiography or ECG or EKG. This is complex of all waves during one electrical cardiac supply recorded by EKG, ECG or electrocardiogram. Electrical voltages generated by heart are recorded by EKG from surface of the body. There are three major components of this EKG. These three components are P wave, QRS complex and T wave. P wave represent atrial depolarization, QRS complex represent ventricular depolarization and T wave represent ventricular repolarization. P wave has been described more, marked by a red circle. P wave represent again atrial depolarization. P wave occur before atrial contraction. Atrial contraction or A wave of atrial pressure tracing occur after P wave of EKG. Let us describe QRS complex. It represent this description is represented by yellow circle. It represents ventricular depolarization and ventricular contraction or systole starts after QRS complex of EKG. Q wave is depolarization of ventricular septum. R wave is depolarization of ventricular wall and apex, and Q wave is depolarization of ventricular base. Let us describe T wave. Description is represented by blue circle and it represents ventricular repolarization. QRS complex occur before ventricular contraction. End of ventricular contraction occur after T wave of EKG. We see ventricular repolarization represented by T wave, but we do not see atrial repolarization. Atrial repolarization is described and marked by yellow square, and it starts at the beginning of the QRS complex and it merges with the QRS complex, so it is not seen as a separate wave. Let us describe different segments and intervals. Let us start with PR interval represented by red square. Some wave complexes of EKG do not have Q wave. In this situation, PR interval start with onset of P wave and end at peak of R wave. But if Q wave is present, then this PR interval should technically be called PQ interval. Normal range of the PR interval is 0.12 to 0.20 second or on average 0.16 second. PR interval decreases with increase in heart rate and vice versa. PR segment is an isoelectric or flat line between end of P wave and start of Q or start of R wave. It represents AV node depolarization, but there is no upward wave. It is usually flat line. Time range of this segment is 0.15 to 0.2 seconds. Let us describe ST segment. It is also isoelectric of flat line, and if it is elevated, it means myocardial infarction. This segment is between end of S wave and start of T wave. T wave or ventricular repolarization duration is 0.15 seconds. Let us describe QT interval. It starts with onset of Q wave and it ends with end of the T wave, and its duration is 0.35 seconds. Basically, QT interval includes ventricular depolarization and repolarization. It represents electrical ventricular systole. Last part of this figure is described by a blue square, and it represents time to start ventricular repolarization, and the duration has been shown 0.20 to 0.35 seconds, and it starts with onset of Q wave and ends with start of T wave. This figure is about calibration of normal EKG. This figure has shown two QRS complexes. Bottom part of this figure shows dark lines and light lines. Dark line makes a large square, and each square has 5 small boxes on the vertical axis as well as on the horizontal axis enclosed in each large square. Bottom part of the figure shows a small box, and vertically it represents 0.1 millivolt, and horizontal axis it shows 0.04 second. Each side of the small box is 1 millimeter in length. So large square drawn by dark lines has length of 5 millimeter horizontally as well as vertically. 10 small box vertically or 10 horizontal light lines on vertical axis make 1 millivolt. EKG is run at a speed of 25 millimeter per second. 25 small boxes on horizontal axis is equal to 1 second. 10 small boxes on vertical axis, as I told before, is equal to 1 millivolt. 5 small boxes on horizontal axis is equal to 0.20 seconds. Heart rate is reciprocal of RR interval. Heart rate is equal to 60 upon RR interval in second. This figure represents recording depolarization and repolarization waves in cardiac muscle fiber by a meter with 2 electrodes, negative and positive electrode. Cardiac muscle fiber is represented by cylindrical tube A, B, C, and D. Right side of the cylindrical tube is showing depolarization and repolarization waves in formation. On the left side of the meter, I have described some basic principles of this figure. Depolarized means negative charges outside and positive charges inside of cardiac muscle fiber. Next, repolarized or polarized or resting state means positive charges outside and negative charges inside of the cardiac muscle fiber. Keeping this principle in mind, let us look at cylindrical tube or cardiac muscle fiber A. Left half of this fiber is showing negative charges outside and is half depolarized. Right-sided half fiber is polarized or resting state, showing positive charges outside and negative charges inside. because half of the fiber is depolarized and half of the fiber is polarized, or at resting state current flows, and you can see peak positive wave on the right side because left electrode is at negative charge and right electrode is at positive charge. Let us move to cardiac muscle fiber B, which is completely depolarized, showing negative charges outside and positive charges inside, and no current flows. And depolarization wave on the right side of the figure reaches to baseline 0, and both electrodes are at negative charges outside. Let us move to cardiac muscle fiber C, which is half repolarized on left side and half depolarized on right side, and current is flowing. Left half repolarized segment shows positive charges outside and negative charges inside, and right half depolarized segment shows negative charges outside and positive charges inside. Right side of the diagram shows peak negative, and left electrode is at positive charges and right electrode is at negative charges. Let us move to cardiac muscle fiber D, which is completely repolarized and no current flows. Cardiac muscle fiber shows positive charges outside and negative charges inside. Right side of diagram shows repolarization wave return to baseline 0, and both electrodes are at negative charges outside the fiber. In this figure, monophasic action potential of ventricular muscle fiber has been compared to electrocardiogram or ECG. EKG paper calibration applies only to ECG but do not apply on ventricular muscle fiber action potential. Left-hand side of this diagram show R wave is positive by 3 to 4 millivolts, whereas depolarization of action potential measures 110 millivolts, which does not fit for this EKG or ECG paper calibration. 110 millivolt action potential is direct measurement in the ventricular muscle fiber, whereas EKG is the measurement of fraction of electricity that reaches to the surface of the body. That is why value is just 3 to 4 millivolt against 110 millivolt of action potential of ventricular muscle fiber. Ventricular muscle action potential shows rapid depolarization followed by slow repolarization or plateau, and then rapid repolarization. QRS complex coincide with depolarization followed by ventricular contraction. Let us explain what is monophasic action potential. For monophasic action potential recording, one recording electrode is in ECF or extracellular fluid and other is in ICF or intracellular fluid. For biphasic action potential, both recording electrodes are placed in either ECF or ICF. In this figure, surface of a cardiac muscle mass is depolarized in its center and the periphery of the mass is polarized or at resting state. The current is flowing outward from the center of the mass to the outward means from depolarized to polarized area outwardly in the cardiac mass, as shown in figure, left side lower corner of the figure. Positive and negative terminal of meter are connected to depolarized and polarized part of cardiac mass in different patterns. Left-sided meter is recording negatively because negative terminal is connected to positive polarized part of the cardiac mass and positive terminal is connected to negative depolarized center part of the cardiac mass. Middle meter is recording 0 because both positive and negative terminals are recording at positive or polarized part of the cardiac muscle mass, which is peripheral part of the mass. Right-sided meter is recording positively because negative terminal is connected to negative or depolarized part, central part of the cardiac mass, and positive terminal is connected to positive or polarized part of the cardiac mass, which one is the peripheral one. This figure shows flow of current in chest around partially depolarized ventricles. Marked number 1 shows depolarized ventricular septum. Marked number 2 show polarized ventricular wall or resting ventricular wall. Current flows through fluid around ventricles along elliptical paths from depolarized area of septum, that is electronegativity, to polarized area of ventricular walls, that is electropositivity. If we take average of all lines, then we can say average current flows from base or negativity to apex or positivity, then from endocardial surface to epicardial surface, and then from apex to base. Last part to depolarize is outer wall of base. This figure is about electrodes for standard limbs, ECG leads, Einthoven triangle, and Einthoven law. Einthoven triangle is shown on the chest in this figure with one apex of the triangle facing downward and two apex of the triangle at the shoulder level. Both terminal of down apex of the triangle are positive. Both terminal of left shoulder apex of the triangle are negative. Right shoulder apex of the triangle has one terminal negative and one terminal positive. Each limb has its own potential. Left arm has potential of minus 0.2 millivolt and right arm has potential of plus 0.3 millivolt and left leg has potential of plus 1.0. There are 3 meters shown and each meter is recording difference of two limbs potentials. Top right meter is recording potential difference of 0.5 millivolt between right and left arm. Mathematical calculation of this difference is shown. Right lower meter is recording positively the difference of potential, that is 0.7 millivolt between left leg and left arm. Mathematical calculation of this difference is shown on the diagram. Left lower emitter is recording positively the difference of potential, that is 1.2 millivolt between left leg and right arm. Einthoven law is mentioned on this diagram, and it states that potential of lead 1 and lead 3 together is equal to potential of lead 2. This figure shows normal ECG of 3 standard limb leads 1, 2, 3. You can easily recognize that voltage height of QRS complex in lead 2 is highest and is equal to sum of voltage heights of QRS complex in lead 1 and lead 3. This is called Einthoven law. This figure is about ECG connection for chest leads. There are 6 chest leads shown on the diagram. Chest leads 1 and 2 or V1 and V2 are closer to base of the heart, while chest leads 4, 5, 6 or V4, V5 and V6 are closer to apex of the heart. There is a transverse section of the chest shown on the right side of the diagram, along with chest leads locations. There is one positive terminal from each chest leads location and one negative or indifferent or Wilson terminal as shown in the diagram. Limbs leads are also shown in the diagram, connected to a central indifferent point. This figure is about normal ECG for standard chest leads. QRS complexes in V1 and V2 are mainly negative, and chest electrodes are closer to base of the heart. Leads V4, V5 and V6 are mainly positive QRS complexes, and chest electrodes are closer to apex of the heart. This figure is about normal ECG for augmented unipolar limb leads. There are 3 sets of the leads. We have studied 2 sets of the leads already. One is chest lead and other is limb leads. Now we are studying augmented unipolar limb leads. There are 3 augmented unipolar limb leads: AVR, AVL and AVF. 2 of 3 limbs are connected through electrical resistance to negative terminal of ECG, and third limb is connected to positive terminal. QRS complex in AVR is inverted and positive terminal is on right arm. In AVL, QRS complex is positive and positive terminal is on the left arm. In AVF, QRS complex is again positive and positive terminal is on left leg. This figure is about normal 12 lead ECG. This is showing 3 sets of leads. Number 1 standard limb leads, number 2 augmented leads, number 3 precordial leads or chest leads. This slide is about discussion for ambulatory electrocardiography. Standard 12 lead EKG is done one time in clinical setting, often miss infrequent cardiac events like arrhythmias. Ambulatory ECG provide extended recording of ECG while patient is doing his or her daily life activities. Symptoms indications for ambulatory ECG are chest pain, syncope or fainting or near syncope, dizziness, irregular heartbeat or palpitation. Continuous recorders or Holter monitors are used for 24 to 48 hours to look for ECG event. Intermittent recorders are used for longer periods like weeks or months. Recording are initiated by patient when experiencing symptoms. Implantable loop recorders is a large paper clip sized device. It is implanted under chest skin to monitor heart continuously like 2 to 3 years. Device is programmed to start a recording of heart rate falling less than or greater than above a predetermined level or manually activated by patient when symptoms like dizziness occur. Rapid online computerized analysis of data. Improvement in solid-state digital technology and recorders equipped with microprocessors now permits continuous or intermittent transmission of digital ECG data over telephone lines and sophisticated software systems. Newer wearable devices like watches and handheld ECG monitoring device for home-based heart rhythm monitoring. Thank you very much for watching this video. Hope you enjoyed this video.